We're now joined by health activist Dr. Kgosi Letlape, as well as Dr. Nocholas, who is the Deputy Director General from the Department of Health. Gentlemen, thank you, as always, for availing yourself to SABC News. Let's start here. Today, of course, marking Freedom Day and looking at the health sector in particular. Would you say that, South Africa is managing to bridge the gap of inequality in providing access to basic needs like health? And I mean, when one looks at the state of, say, many public hospitals, it doesn't seem that way. Dr. Letlape, let's start with you as a health expert, but I'm really posing the question to both of you this afternoon.
No, we have not lived up to the promises of Section 27 of the Constitution, which talks about one nation, one health system, one group of people. But in practice, we have no solidarity. Those of us who have our own separate system with our dear parliamentarians and politicians. And until we have a system that unites all of us, that is based on solidarity, that is accessed based on need rather than affordability, rather than your status, your wealth, or whether you are employed or unemployed, you are a child that is from a rich family or not. Until we get to that, we have not lived up to the promises of the Constitution.
Dr. Crisp, I mean, the same question to you, but I think I'll add more to it. I mean, you're with the Department of Health, and that's government, as Dr. Letlape refers to there. Why is that the reason? Why have we not lived up to, the promises made, and why is our health situation in such a dire need, and especially when it comes to state and government hospitals?
Yeah, thanks very much. Good afternoon to everybody. I must agree entirely with Dr. Letlape. We have an extremely inequitable healthcare system in South Africa. We have a completely parallel system where the private sector and the public sector function as if they're in different countries. And we have a huge amount of resources that we haven't managed to harness. So that's the challenge, and that's why we want to change the way the system is structured. Yeah. We want to have one system where we all participate and we get healthcare, as Dr. Letlape said, because we need the healthcare, not because we've got money to pay for it or we've got influence in the system. Why we don't have is complex, and it has deteriorated rather than improved over the last 25 years. And that is exactly why we want to implement the National Health Insurance, where we can get everybody to have access to all the resources in the country. I'm sure we'll talk about how to do that.
Yeah, in fact, I wanted to do that. I want to do that now, Dr. Crisp. I mean, you're talking about changing how the system is structured, and where do we begin? I was actually talking to one of the health insurers recently on the show, I think a week ago, and it had been said that it seemed as though the health insurance companies, there was some sort of pushback from them, and there was a bit of a denial from them, saying no, in fact, we'd love to see the NHI going through, and in fact we can work hand in hand with government. Is that true, and is that the sense that you get? Is there support from other sectors? Because with many things it can't just be government pushing something. I mean, what is the stumbling block at this point, and what is this changing of system and how it is structured that you speak of?
Yeah, look, there's huge pushback from a lot of stakeholders in the system. If you have privilege, if you have access to resources, you will push back because you fear you're going to lose something. Yeah. But if you're someone who has nothing and doesn't have access to things, and there's a promise of getting more, then you're in favor of it. I mean, we must recognize that there's a spectrum here. But the fact of the matter is we spend 8.5% of our gross domestic product on healthcare, and we're spending half of that on a very small proportion of the population who are either able, through their pre-insurance of their medical schemes, to purchase very expensive healthcare. And we have the other half of the money that is being allocated or that we use through our public health system to look after the vast majority of the population. I don't want to get into arguments about the exact percentages because it's not relevant. Yeah. The divide is massive. And what we need to do is to harness all those resources. So obviously, if your business is based on an administrative overhead fee for managing a very small portion of the population with a large section of the money, you will feel threatened by the model which is going to have one system with everybody enjoying the same benefits, very publicly available, and provided by everybody. There's no intention in the bill or from the department or any of the players to do away with private health care. There's plenty space for people who work on their own in the private system to deliver health care to everybody. And it's the way in which we do that and pay for it that matters going forward.
All right, Dr. Letlape, let me bring you in here. I think it's interesting that Dr. Crisp talks about, some people feeling, of course, threatened, and it really is a situation of, haves versus the have-nots. How do we begin to make people, and when I say people, I'm probably talking about the haves, how do we begin to make those people understand that it's actually not feasible in our country to have such a huge gap, such a huge equality gap, particularly when it comes to the health sector? Where do we begin to start having, we're having that conversation now, but where do we begin to have that wider conversation about that? It's simply not feasible.
Well, it's time for action, as Nocholas says. I think the privileged know that they've had it good for too long. They are hanging on to the coat strings of apartheid legislation. And what is required now is decisiveness and leadership. And we have to stop pussyfooting. The Medical Schemes Act is not private health, it's privatized health. And as Nocholas says, the 8.5 or whatever percentage it is needs to be pulled together into one common fund that serves all South Africans. And we should stop confusing people about private separateness from funding and private provision. Private provision has always been here. Even before medical aid was strong, but in the 70s, when the first heart transplant was done in the 60s, private provision was there. We went to see private GPs within an efficient public healthcare system. So let us stop confusing people about what is private and what is not private. And what needs to be done, health needs to be a national competence. The Medical Schemes Act needs to be scrapped. And people need to be re-educated about what has been happening. We need to pull the funds together and build a health system that all of us will use, including the president of the country, the parliamentarians that we voted in, and privileged South Africans like myself and Nocholas. We should be there with Gogo Dlamini and everyone else and build a system that we will also use, that will be used by everyone, so that we live up to Section 27 of the Constitution that talks about within available resources. It doesn't work to put them in separate pots. There are excellent things that we can retain from the public healthcare system. There are excellent things that we could learn from the medical aid and privatized system. But it is time we build a unitary system that is based on civil service that serves all South Africans.
Well, Dr. Crisp, the argument that I often hear is that, if public hospitals, if government hospitals were in great shape, people wouldn't have a problem, and they would certainly not want to be paying these exorbitant fees that they do to have health insurance or to be on medical aid. How will we then be able to, and as Dr. Letlape says, there's good we can take out of public hospitals, there's good we can take from private hospitals, but how do we then manage to combine that without making people feel as though, personally, as someone who's got health insurance, I would not be comfortable to be paying an exorbitant amount of money to be on health insurance, and knowing that I'm also bridging the gap for other people to be at the same hospital. And I suppose that's how a lot of people feel. Why am I paying so much money to make sure that everybody else has access? And I think that's also where we need to also maybe change our mindsets.
The first response to that is, why do you assume you're going to be paying more money than you're paying at the moment when the models show that you will be paying less?
Well, even if I am paying the same, it's still exorbitant. So even if it was to stay, let's say So let's have a look at the moment. So this year, the health budget in the public sector was cut. The tax revenue that is invested in the public health system has been reduced this year. At the same time, the medical scheme's average increase for those of us who have medical aid and are privileged has gone up 8.9% on average, which is way in excess of inflation. And we tolerate it.
and we get less and less for the healthcare that we think we are buying. It's a trap that we have got ourselves stuck into, and it's a systemically badly designed trap that we are in, where it is the private sector is designed in such a way that it absorbs and consumes resources, and it becomes a situation where there's so much competition that you have to charge more or do more, even if it's not necessary. Whereas in the public sector, it's an attempt to do less because you've got less and less resources, less and less people, and less money to do the work that needs to be done. And if we can find some form of balance between these two equations, and we are able to use the 2/3 of all the country's specialists who are in the private sector to look after people who are currently in the public sector, and if we use the general practitioners and medical officers to do the work that we've trained them to do, in the public sector, by the way, then we have enough resources to do a lot more for all of us without having to be intimidated or threatened that our care will decrease. As Kgosi said, that's what we were exposed to even in the days of the homelands in the 70s and the 80s. So we know it's doable. We've been there before. And right now, we've just created a monster of a system that neither works for the public or the private patient.
Yeah, yeah. Dr. Letlape,
also
yeah, sure. You can go in. You can come in. Yes.
You actually don't have health insurance.
Yeah.
You have Medicaid. And this is a thing that has been created. What you have is based on an act of parliament that divides us as a society. That is one of the key factors of what we have. And you think it is insurance. It is not insurance. Most of the Medicaid are compulsory conditions of employment. People don't choose. It is not volitional. It separates us. You have families where the father is on medical aid, the wife is not, the children are not.
Yeah.
Where grandfather is on medical aid and the rest of the family is not. It's something that divides families, that divides society. That is an act of parliament.
Yeah.
That act must go. And then we can speak of it's my private money. You know, there's no act that helps us take our children to private schools.
Yeah.
There's no tax benefit. We do it out of our own money after we've paid our taxes.
Yeah.
So no one should rightfully speak of private health in this country when it is based on medical aid. The people that pay out of pocket, that see private practitioners, can speak of private health. There are many, many people in our country that use traditional healers, where there is no medical aid, where they pay out of their own pocket. They can talk about being in a private system. But those of us that are on medical aid are on the coattails of apartheid and privilege.
Yeah.
And we should stop confusing ourselves, saying it's my money. No, it is what Parliament has carved out. It is what exists now from previous apartheid legislation, and it is time we cleared it from our statutes.
Yeah, Dr. Letlape, I mean, you know, as doctors, when you consult and when you have consulted day to day, and on this, what you're talking about now, let's talk about what, some of those challenges that, your patients have in terms of accessing quality health, whether it be the issue of finance or medical aid. And I think you're talking a lot about inequality and addressing it, and that's important today.
Yes, remember, when we talk about accessing what you need based on your healthcare needs, when you look at what happens in this diabolical insurance system, what is needed is taken out of pocket, is taken out of benefits, it's taken out of minimum benefits.
Yeah.
It's run like an insurance scheme, and they're looking for, if something is prevalent, they don't pay for. People forget that the medical aids were refusing to pay for HIV, AIDS, and care, because they felt they would be bankrupted. So where there's a need, they do not. If you go into a healthcare system that's based on need, when we have something that is common, we then ensure that the scientific world, the administrators, the government, we come together to say, how do we resource this? Just like we did when it came to COVID, under the leadership of the government. How do we make sure that anybody that needs a vaccine gets that vaccine? How do we ensure that anybody that needs a test gets a test? and they don't stay out of the system. That is how a national health system operates.
Yeah.
I mean, that's what we need, Flo. And this business of savings account, you are fully covered as long as you don't get sick. When you get sick, you got co-payments and you go bankrupt. It's time we wisen up as South Africans and we build a system for our children.
All right. Dr. Crisp, let's wrap up the conversation with you then. And I think the last time that you and I spoke, we did actually talk about this, but, for the benefit of this discussion, maybe if we can, touch on it once more. When I was asking about the progress that's being made in terms of the NHI bill, I think we all agree that the system does indeed need to change. Let's talk about the progress and when it will be implemented. And I just have to say, as a side note, and this is something that I spoke about with the insurance company I spoke about. You said I shouldn't say health insurance, but anyway, the health insurance company that I spoke to, I said, we've been talking about this for many years, and I still remember the former health minister, Dr. Aaron Motsoaledi, really pushing on this issue of NHI, and one wonders, where are we now?
Yeah, so thanks very much, Flo. So what's happened is that the bill was tabled in Parliament in 2018. 2019, it's been through a long process of consultation, as is our want in our constitution and the way we formulate laws in the country. The Portfolio Committee of Parliament has had roadshows, it has received written comments, and it has now heard 117 oral comments. And they have then called the department several weeks ago to come and respond, and we have done that. We've responded in Parliament, and the record is there for the public to hear how we responded. They now contemplate whether there should be any amendments to the text, and they will do that and engage with the department. Then it goes to a vote, and it goes to the Council of Provinces for consultation before it comes back to Parliament for a final vote of the joint houses. That's a process that Parliament has told us they would like to conclude this financial year. And while they're busy with that, we in the department, and that's my job, I'm the Deputy Director General responsible for National Health Insurance, we are putting together the administrative capabilities to do what the bill says are the functions of the fund. It's quite a long story, and building from pretty much from scratch. There are a few of the functions that are going to slightly transition from the way they've been done before, but many of the functions are completely different. As Kgosi said, pulling together what the public and the private sector can do, and how we should be paying for and what we should be paying for to make sure that everybody gets healthcare is a long road, and it's not something that, as the media would want the public to believe, or the naysayers would want the public to believe, will switch on at a date next year. That's not how it works at all. It gets phased in. It's very clear how those phases work. They're described in the bill, and we will put flesh to that during the course of this year as we get more technical personnel to work with us. So we are happy that we are making good progress. We lost 2 years of time because of COVID, but we didn't lose everything, because during COVID, as Kgosi also said, we learned a huge amount about working together as providers in the public health space with our private colleagues, and it went remarkably well. And we are continuing to work together on a number of projects and a number of initiatives to make sure that healthcare is available to all. So I'm happy we're on track. It's slower than we would like it to be, but that's the nature of the game.
All right. Thanks very much to both of you, Dr. Nocholas Crisp, Dr. Kgosi Letlape. Appreciate your time, especially coming through to talk to us on a public holiday. Much appreciated, sirs.